Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. In this programme, we take a look at chest pain. Olga Ward caught up with cardiologist Dr Jenny Deague and emergency physician Dr Ian Dey at Armidale Hospital to discuss a range of problems associated with chest pain. But before we begin, Belinda Bailey, CEO of Rural Health West, has a quick word about Rural Health West's complementary recruitment services for rural and remote practice.
As you know, Rural Health West is in the business of recruiting and retaining GPs to country WA. And here at Rural Health West we have a dedicated team specifically to help you recruit doctors to your practice if you need one. But we have a process, and I thought I'd just step you through the process to make sure that if you do come and work with us to recruit a doctor, then you'll know what's involved. I think the most important thing though to say up front is that any of our recruitment services that we provide for you are totally free of charge, and there won't be any sort of financial considerations for you. So the first step in our process is for our staff to work with your staff to develop a practice profile. And a practice profile basically is gathering information that we need to attract and recruit a doctor to your place. What we put into the practice profiles is that we need information about the sort of patients you see, the sort of skills that you're looking for in a new doctor, information about the package, the financial package that you're going to offer a potential recruit. We need to know about your community, we need to know about the region, and we need to know about all the wonderful and positive aspects of living in your community to help us get the right doctor for your place. So once we have a practice profile, we go to the next step, which is case matching. Case matching is when the team here scroll through all of our databases to find a CV that may well match with your practice profile. The next step is then to see whether or not this is really someone who you are interested in recruiting. And if all goes well, then what we do is we actually case manage that potential recruit. So the case management process is about one of our team working one-on-one with a potential recruit to navigate them through all the complex pathways of coming from either overseas, interstate, or even just from within Western Australia. That process includes supporting that doctor with all the immigration processes, 457 visa applications, supporting them with their application to the Medical Board of Australia and the very complicated pathways to medical registration for international medical graduates. It also involves making sure that if we find a doctor that you've offered a position to, that when they arrive at your town and your practice that they're ready to work. So they need to have a provider number, and that's part of the case management process. Of course, the case management process involves making sure that any new doctor to Western Australia has access to one of our, what we think are very high quality orientation programs, which ensures that they're familiar with the Western Australian health system. And then last but not least, but which is also probably the most important element of the process, is to make sure that their spouse and their family are connected to the family support program and the Rural Medical Family Network. So that's kind of the whole case management process, and if all goes according to plan, we should have the right doctor for the right practice in the right community. That's our aim, and we're pretty passionate about making sure we put the right person in the right place. So if you do have a recruitment need, please don't hesitate to contact the team at Rural Health West. We'll be really thrilled to help you.
Thanks, Belinda. Now let's join Olga Ward and our guests, Dr Jenny Deague and Dr Ian Dey.
So Jenny and Ian, welcome to the program.
Thank you.
Thank you.
Things that puzzle country GPs really are patients who turn up with what looks like really severe chest pain, and it's not typical of ischemic chest pain. Doesn't really seem to be pleuritic, don't have any history of trauma. How do you start sorting out patients who present to an ED with chest pain?
Ian, you're the ED doc.
Okay. It's common, and the reality is with patients presenting to emergency departments with chest pain that a small percentage of them have something nasty going on, acute coronary syndrome or PE or dissection or some potentially serious diagnosis, but most of them we don't find an obvious cause for. And a lot of them do complain of very severe pain, 10 out of 10 if they're asked to sort of rate it on a scale. But the process of teasing them out is much the same, and patients when they arrive with chest pain need basic vital signs, the usuals, pulse, blood pressure, respiratory rate, SATs, temperature, and they need an ECG. And then once you know whether you're dealing with a patient with a diagnostic ECG, at worst an ST elevation MI, and or a patient with abnormal vital signs, then you know which direction it's sort of heading. Now this scenario is talking about the patient with normal vital signs, normal ECG. At that point it's predominantly about the history, and it's predominantly about really good thorough histories that look at all of the things that we associate with that. So the nature of the pain, the duration, its radiation, associated features, sweating, nausea, comorbidities, you know, smoker, cholesterol, blood pressure, etc. Examining the patient, of course, but then sort of tests based on what you think is going on at the end of the history. And that scenario of the well patient with a normal ECG but severe chest pain is common. Meanwhile, of course, analgesia for the patient that helps enormously.
What sort of analgesia would you choose on somebody like this with this very undifferentiated sort of pain?
For patients with acute severe pain, narcotics early on to help settle down the pain. If the pain is less severe, or from the your gut feeling is that this really doesn't require narcotics, then something else appropriate, depending on what else the patient's on. But I guess the answer is everything up to and including narcotics. And if you present to an emergency department with severe chest pain, unless there's a reason not to, narcotics like titrated morphine will be a common part of the management. And for the most part we just use IV morphine, small boluses, 2.5 milligrams or so in an adult, just titrated to where they're comfortable.
Jenny, cardiac pain can sometimes also seem to be something completely different. It's almost the opposite thing, that you may instead get an earache or an arm pain or a jaw pain. Is there a quick kind of sorting out test or therapy trial that might tell you this is cardiac?
I don't think so, no. I think you've got to go back, exactly as Ian said, and you've got to take the good history and find out, have they got a big cardiac history, what have they been on, what other medicines are they on, you know, have they taken Viagra, so will it be suitable to give them nitrates, things like that. I think you need to go back to history, examination, are they stable? Then of course you've got the troponin, which is, you know, a great advantage to us, assuming that the patient doesn't have renal impairment and a high troponin, or for instance a pulmonary embolus could have a high troponin, but troponin can be very helpful in this circumstance where you're not really sure and you think this jaw ache, is it a toothache, do they need a tooth extraction, or could it be cardiac? And that can be very difficult to work out, and it's only when you do the troponin, find that the troponin's raised, and then go on to further things such as stress testing, that the nature of the chest pain will become clear.
Troponin, you said renal failure might elevate the troponin test.
Correct.
How much renal failure and how much elevation?
Yes, well it's not much, it's a low elevation, and often in the renal failure patients someone may have done a troponin previously, you know what their baseline is, so you can see a rise within that level. But often the patients come in, you know, the mild renal impairment with, you know, say an EGFR of between 50 and 60 and a slightly raised troponin. I think you still have to have the suspicion of cardiac disease, you know, because having mild renal impairment itself is probably a risk factor for cardiac disease, given they may well have diabetes or hypertension or any of those things also contributing to the renal disease. But if you've got someone, a true dialysis renal failure patient, the troponin is going to be much less helpful.
You were talking about nitrates being given to a Viagra patient. What would happen if you gave a nitrate to a patient who had some Viagra? Because sometimes the patients aren't going to tell you.
Sometimes the patients aren't going to tell you, and you have to ask that direct question if you're concerned about that. But basically hypotension. You know, Viagra and nitrates don't mix at all, and it causes hypotension. And the last thing you want is you've got someone who's got crushing central chest pain after they've used their Viagra and had a rigorous round, and you give them some nitrates and they have a collapse. And then you've got all the dilemma of that.
Yeah. So what would you do instead?
I would ask direct questions. I wouldn't give nitrates. You can't reverse the Viagra, but you need to use other medications, your IV morphine, beta blockers, all of that is fine and safe. It's just the nitrates.
Right, so the beta blockers will still give you some useful cardiac perfusion where the nitrates are not a
well, they'll settle down the cardiac ischemia. Assuming the patient has cardiac ischemia, beta blockers are a wonderful thing, particularly if they're given, you know, in boluses intravenously. They're a lovely thing for controlling the heart rate and controlling the chest pain.
Now, the ones that I find very difficult to get a handle on are the ones who have pain in the chest wall. Is that ever cardiac?
Never say never. It's always very reassuring if we find someone with chest wall tenderness and we poke them and then we think, oh, it's probably just musculoskeletal. But I think you have to once again go back to the very standard thing of take a good history, a good examination.
Yeah, I'd agree. I think chest wall tenderness is exceptionally common, and if you just grab a whole lot of people off the street and push points in their chest, it's often tender. So you've got to be careful how you interpret that. I think chest wall tenderness, if you come to the conclusion at the end of a decent history that this is probably musculoskeletal, then the finding of chest wall tenderness might be useful. Yep. But you've got to be very careful interpreting chest wall tenderness as diagnostic if your history sounds like a PE or acute coronary syndrome or one of the others. There's been some studies done with patients with proven acute coronary syndrome that show that you can reproduce chest wall tenderness in a lot of them. So I think the takeaway message is that chest wall tenderness does not exclude other pathologies, and it comes back to what you clinically thought was going on and whether that sort of supports that or not.
If you've actually got some pleural irritation, for example, if you've had a pulmonary embolus or somebody's got a little effusion or a chunk of pneumonia or something, does that actually produce chest wall tenderness so that if you push on the corresponding external part of the chest wall, you will also get them to squeak?
I think patients with will often complain of chest wall tenderness when they've got pleuritic pathologies, but it's not severe chest wall tenderness, it's sort of mild to moderate, but a bit like the patients with renal colic have often got mild tenderness over the area, and there's no real, you wouldn't expect them to have tenderness as a result of renal colic, but they do, whether it's because they're telling you that that's localising the pain, whether it's because patients with severe pain when they breathe think that area should be tender, I'm not sure, but often mild or moderate sort of amounts of tenderness are common. It's not usually severe though. Patients with a pleuritic pathology shouldn't be yelping when you are touching bits of their chest wall.
So somebody with a pulmonary embolus, say, what would you consider to be the cardinal features that would give you a red flag that this patient's going to have a pulmonary embolus?
Well, the cardinal features are pleuritic pain without other explanation, and a lot of patients won't necessarily have other features. They present with definitely pleuritic, so it's relatively localised. It's almost always unilateral. Worse with deep breaths. They don't complain of vague pain, heavy pain, just a sort of a vague one-sided pain. And then you look for the other features of PE, tachycardia, syncope prior to presentation, hemodynamic instability, ECG changes, risk factors of PE, calf pain, travel, swelling, family histories, medications, particularly oral contraceptive pill. But it's really if patients present with unilateral pleuritic pain and you don't have an alternative explanation, then you need to think hard about whether PE is a possible cause.
Yeah. Country area, ECG changes for a pulmonary embolus?
Well, the classic changes are, those of right heart strain. So S1, Q3, T3 would be the classic signs. A tachycardia on its own in an oxygen setting, an oximeter, and just look for low oxygen saturations, or blood gases to look for low oxygen would all be signs of a pulmonary embolus. Or if they've got the pleuritic changes, you might even hear a pleural rub, which is quite a loud, harsh murmur that you can hear.
I guess in addition to that, occasionally supraventricular arrhythmias that might present with a PE, and again, if somebody along the way ordered a troponin, and that troponin's sort of mildly elevated, but then in the wrap-up it doesn't necessarily sound like acute coronary syndrome, then PE is an explanation for mildly elevated troponins as well.
I'm just thinking about the kinds of investigations and things that you do have in a very small country ED, which would be probably in a chest X-ray.
Chest X-rays are usually normal in PE. The vast majority won't have any changes. And that's useful though, because it helps you exclude other pathologies that present with pleuritic chest pain, pneumothorax for example. So a normal chest X-ray, although it doesn't help confirm PE, is useful to exclude other things. A D-dimer, I guess D-dimer being a bedside test, point of care test, a lot of places will have. And it is very, very useful in PE, provided you do it on the right patients. and that's where the Wells criteria, which if you can't remember, you just you can find them on the internet.
Yep.
So Wells criteria in terms of risk stratifying PEs, and then some other criteria called the PERC criteria, which are helpful for teasing out whether low risk patients need any further investigation at all. So 2 clinical rules to remember if you're looking to investigate PE.
And the other thing I think that's quite scary for a general practitioner on their own in a country ED is the dissecting aneurysm.
Yeah.
That's scary for everyone.
Which
Yeah,
is,
that is,
It's scary for us in the big EDs.
Yeah.
I mean, the scary thing about that is that it's quite rare, but when it happens, it's of course life-threatening. You know, very much so. The thing to look for is differential pulses, different blood pressures in both arms, if you think it. The patients will present with a crushing pain that they often say it's tearing towards the back, okay, because literally the aorta is tearing. So it is, once again, back to the history, and the history is really important. These guys do give a different history. They don't have the jaw ache and all. It crushes, it goes through to the back. And then it's worth just doing the blood pressures in both arms and seeing if there's a differential, do a chest x-ray to look for a wider mediastinum, and most importantly, hold back on the anticoagulants. These are not the chest pains to give aspirin, Plavix, tirofiban and heparin, and then find out they've got an aortic dissection.
Yeah.
And that's really hard, and not missing that. It's something, I think when you see a chest pain, you always think, okay, what are the things that are going to be crucial that will kill a patient if I don't get it right? And aortic dissection, pulmonary emboli and acute coronary syndrome are the things. And I always, when I'm seeing an acute coronary syndrome, because that's the first thing in my mind, I'm always thinking, now Jenny, could it be a PE, could it be a dissection?
Mm-hmm. If you did have a patient having a dissection, what would you say? What would you see on their ECG?
You may see nothing at all, or you may see an acute infarct if it's affecting the coronary arteries. So, you'll probably see tachycardia because they will be in pain and they'll be hemodynamically stressed.
So really, that it's going to come back to the history. If you've got you know, somebody that's going to take 2 hours to get in to do the
chest X-ray can be very, that's correct. The chest X-ray, a well-centred chest X-ray can be very helpful because, you know, a lot of chest X-rays you're not, if it's off-centre, it's not helpful. Yeah. But if you really have clear evidence for wide mediastinum, you've got differential pulses in both arms, and while you're working it out, hold back on the anticoagulants and maybe try and control the blood pressure, because often aortic dissections occur in the setting of long-term high blood pressure, and controlling the blood pressure and getting the blood pressure down is very important for an aortic dissection.
Would you try to do that if you had a patient, say, just having an infarct, if their blood pressure was, I don't know, 185 on 100?
Yes, but a fantastic way of treating blood pressure in the setting of acute coronary syndrome is with good analgesia.
Yep.
And that's why things like adequate amounts of narcotic are good, because you've got all sorts of things driving that high blood pressure, not least of which is just pain and the sympathetic response from pain. But then also nitrates, of course. And my experience is that if you've got, with use of narcotics and nitrates, plus or minus beta blockers, the blood pressure is fairly rarely a problem beyond that in acute coronary syndrome. Reassuringly, with dissection, I think the history is almost always a little different.
Yep.
It's very rare to have a patient who presents with typical acute coronary syndrome who turns out to be dissection. The pain, as Jenny said, the pain has got this very characteristic radiation through to the back and perhaps even down the back into the abdomen if they're dissecting downwards. And also transient neurology. Quite a significant percentage of patients who present with dissection have had transient neurological symptoms that reflect the various sort of vessels coming off the aorta temporarily being affected. So that's something to look out for.
Yeah. And you mentioned blood pressure differential between the arms. How much differential would you consider significant?
Arbitrarily 20
20
is
yes.
the cut-off that we use. Differentials below that are quite common.
And I will emphasise along with Ian about the sympathetic drive, because whether you're having an acute coronary syndrome or an aortic dissection, that sympathetic drive from anxiety and stress and pain is actually very bad for your acute coronary syndrome or your aortic dissection, for all of that. So, you know, pain relief as soon as possible is actually very important in these people.
What about the patients that are a little bit even less typical and they turn up with, say, a slowly deflating pneumothorax?
Primary spontaneous pneumothorax is common enough that you see it, the history is you usually suspect that it may be because they present with sudden onset of pain. The pain is sort of definitely pleuritic, it's worse with a deep breath. Most of these patients are stable. Tensioning with a non-traumatic pneumothorax is relatively rare. So, you know, I guess it's about the clinical suspicion of it from the history, and then occasionally you can find signs of it on examination. A lot of the time you're reliant on a chest x-ray to pick it up.
Yeah. Luckily that's something at least we can fix in a country setting without too much trouble.
Yeah.
The other patients I think that have caught me out occasionally have been somebody who's come in with really quite severe chest pain, and it isn't until 2 or 3 days later that the shingles have come out, and I thought, blast, that's what it was.
Yeah.
How commonly would you see something like that where you've been absolutely flummoxed by what's causing their pain?
Yeah, look, it's commonly enough chest pain and abdominal pain where patients present and then a couple of days later re-present and the shingles is diagnosed. Look, I think it's something that you just have to think about when patients present with unilateral pain that sounds like that sort of radicular pain. It's very sharp, it's unrelenting. And I think you can't always, if they don't have the rash, it's impossible to make the diagnosis, but I guess if you think that if you don't have another explanation, you think it's a possibility, then you're going to structure things around early review, telling the patient if that develops, then come back, because obviously if they do develop that, then you've got, then it may alter your expectations with pain relief and antiviral treatment.
Yeah. Would you actually use an antiviral before the rash came out?
If I was strongly suspicious, then perhaps I would. I think the kind of thing we might do is administer sort of 24 hours of treatment and review the patient the following day or the day after and see if the rash is coming out. I don't think there's a right and wrong as to whether you give the antivirals without the rash, but if you're strongly suspicious, I would have no argument with that.
I think if you've got some sitting on the shelf, you can probably sneak
exactly.
it. Of course,
well,
you can't under the PBS.
I don't think I'd write out an authority script for a full course unless if they hadn't developed the rash, but a couple of tablets that were sitting on the shelf would be reasonable.
It's useful to get into the sample cupboard.
Yeah.
Would that actually stop the rash from coming out, do you think?
I need an infectious disease expert to answer that. My gut feeling is no, but it might shorten their illness significantly. We know that, you know, that there's a window of opportunity for antivirals, so I guess the earlier you give them the better, but I'm not an infectious disease expert.
And the last thing that I think does, in a way, annoy country general practitioners and city general practitioners is a patient with this unexplained chest pain. Sometimes they've been into the hospital and they come back with this kind of, almost looks like a dustbin diagnosis of musculoskeletal pain or costochondritis. What on earth do we do with those? What works?
That's where emergency physicians are deferring to the expertise of the general practitioner, I think, isn't it? So, look, yeah.
Is it a viral entity?
There's no evidence. If you read the literature, no one's really sure what it is. So is it viral? Is it inflammatory? Some people will suggest that non-steroidals will settle it down, which will be great. So I think the main thing is to reassure the patient that this is not of prognostic significance and they're going to do just fine.
Do emergency departments still use injectable non-steroidals?
Yes is the answer, but less so. I think the Toradol or Ketorolac is not without its problems. Again, and we use a small amount of injectable COX-2 inhibitors, but for the most part, non-steroidals are administered orally or rectally. Yep. There's not a massive amount of evidence that parenteral non-steroidals offer a lot in emergency medicine compared with, say, IV narcotics for severe pain.
And then when you've got a patient with pain like this, how long would you expect it to last? Like, are these people that represent to your emergency department?
With costochondritis?
Yeah.
Look, there is a big group of patients who represent with chest pain and we don't find a diagnosis, but I don't think they're patients with costochondritis. Most of they're patients with, tend to be a complex group of patients who, a bit like the patients who recurrently present with abdominal pain and we're not sure exactly what causes it. When we make the diagnosis of musculoskeletal chest pain, most patients subsequently follow that up with their general practitioner, and I guess we're somewhat naive to the problems that the general practitioners have in managing patients with costochondritis perhaps.
And Jenny, do you ever get the recurrent presenters in the cardiac clinic?
Oh, absolutely.
When nobody can sort out what's causing their chest pain?
Absolutely, and I think that's where, you know, stress imaging comes into play, and where you need to, once again, make sure that this chest pain is not cardiac. You've obviously, because they're a recurrent presenter, they're not an aortic dissection or a pulmonary embolus. So you're looking for, could they have significant coronary disease? And that's where a stress ECG or a stress echo or a stress nuclear or possibly even a coronary angiogram can help sort this out. And there's a lot of relief for patients when they discover that their feared cardiac disease is not as bad as they think, or that they don't have coronary artery disease. And then you can go on and use other manoeuvres and measures. You can investigate gastroesophageal reflux disease, you can investigate other things to try and sort out what this pain is. And it is reassuring just when the diagnosis of coronary disease is not made. That in itself is a reassurance to a lot of patients.
Terrific. We might take a break and have a look at some cardiac rehab.
And we'll return to that discussion shortly. As traumatic as it is, a cardiac event is often a good opportunity and a catalyst for embracing a healthier lifestyle. And the benefits of exercise after a cardiac event are well established. But maintaining contact and promoting a healthier lifestyle to rural and remote patients can be difficult. Royal Perth Hospital has a program to support the ongoing cardiac rehabilitation. We spoke to the team about how they support patients in remote areas after a cardiac event.
Hi Ray, how are you going?
Good morning.
I'm Narelle, I'm with the cardiac rehab program here at Royal Perth. Have you been given any information about that yet?
None at all.
No? Okay. The cardiac rehab program was set up in 1999 in Royal Perth Hospital for the purposes of supporting patients following a cardiac event. We predominantly focus on patients after a heart attack with angina or angioplasty, also a few heart failure patients and patients who have ventricular arrhythmias. We run a program of information sessions and exercise sessions for patients to come back to, just to support them after that cardiac event in learning about how to look after their heart, and also giving them some practical experience in the exercise program as well, so they can take those skills home and develop their own home program.
Exercise training following a cardiac event reduces the risk of recurrent events, it decreases cardiac and all-cause mortality, improves quality of life and functional capacity, and helps accelerate recovery. Our exercise physiology service offers supervised exercise for both inpatients and outpatients. We run exercise classes in here 5 days a week for cardiac patients, and we see the whole gamut of cardiac patients, from patients who've had recent MIs through to patients who have advanced heart failure and are awaiting cardiac transplantation. We tailor the exercise program to the age, the level of fitness and the clinical condition of the patient. We use a combination of aerobic exercise and resistance training. Resistance training using light to moderate weights. And we encourage patients to come to the gym here at Royal Perth 2 to 3 times per week, and we give them supplemental home exercise programs to complement what they're doing at Royal Perth.
Alright, I'm just going to check your blood pressure. So I'm just going to put this on your arm up here, and what we're going to do is we're going to pump up the cuff and block off the blood supply to your hand, and with my
They get their blood pressure and pulse checked before they start. They also have a discussion with the staff about how they've been feeling and whether there've been any change in their symptoms. Any of our heart failure patients will also have their body weight checked, just to evaluate them for fluid retention. We check blood pressure and pulse again at the end of every exercise session, as well as take a detailed recording of the activities that the participant has done during the session, their level of exertion during those activities, and we would document any clinical signs or symptoms that they may have experienced.
So it's 120 on 80 there, which is quite good.
We monitor them fairly closely through the session as well. We don't stand over them because we want to develop some independence with exercise because a primary goal of our service is to really give people the confidence to be undertaking exercise in an unsupervised environment in the medium to long term. I guess we're in a fortunate position here to have the equipment that we have in the Royal Perth gym, but you know, a comprehensive exercise program can be achieved with a minimal amount of equipment, and we do need to take the emphasis off just exercise, but encouraging people to be physically active you know, in more of a general context as well. There are lots of services available throughout country WA where people can access exercise options, and we encourage a lot of our country patients to look at what opportunities there are within their community to become more physically active, and that may be joining a formal exercise program in a community centre or engaging a physiotherapy practice, or it might just be becoming more physically active in their everyday life and aiming to accumulate 30 minutes of activity per day through walking activities as well as activities that they're doing around the house as part of their day-to-day routine.
So we do have a multidisciplinary team of health professionals involved in the program. We have myself as a cardiac rehab coordinator, we have an exercise physiologist, we have a cardiac coach who's our telephone follow-up coach. We have an Aboriginal health liaison officer who purely focuses on the Aboriginal patients that come through the service. And we have a series of talks run by different health professionals as well. So we have a dietitian, we have a clinical psychologist, we have an occupational therapist and a pharmacist, in addition to myself and the exercise physiologist who deliver the talks.
And then inside the wire comes out when they blow it up. And when that's in place, they deflate the balloon again and they'll pull it out. My name's Dallas Yaron. I'm the Aboriginal Health Liaison Officer in Cardiology Department here at Royal Perth. And my main role here is to educate and support our Aboriginal patients as they come in through the ward here at Royal Perth, either by flying doctor service or brought in overnight by ambulance or family. And my role mainly is to see them the next morning as I do ward rounds and find out a bit about their heart event, letting the patients understand what's happened to them, finding out their procedures, what they're going to have done, just using our procedure booklets. These are the ones that patients, when they first come in and they see, the first one is like an angiogram to give them our doctors a good picture of what's happening and the patient. So I explain all these procedures to them using this little book on the angiograms mainly, and as they go on in their inpatient stay, they go on and do ECGs, thallium tests, chest x-rays, they do stress tests, and I go along on their hospital journey while they're an inpatient. To have me in this role at Royal Perth is a great thing for our people as they come in from, especially the remote areas in WA. It's a big state, and coming from the top end of WA to Perth is a long way. So most of our patients come down alone, you know, by RFDS. So having me here on the ward when they come in is a big support for them. My role too is to do a follow-up call, and about a week after they go home, we like to find out and see it's a cardiac rehab, so we see them back into their community. We link in with the local Aboriginal medical services. We liaise with them and say we have a patient coming home on Tuesday, they need this sort of care, they need this sort of follow-up. And a lot of our patients don't have the same resources and the gyms and the cardiac follow-up that the city people have. So we just have a yarn with our local health workers and say, you know, he's coming back, be sure to do this with him, and he'll come in. And once the patient presents himself to the Aboriginal Medical Services, then we encourage them to attend regularly. We keep in regular contact until they're back on their feet again. So we also don't forget about them. We say, you know, it's important, if you need any help from us, you just have to call us, and, you know, we give them their numbers. And a lot of our patients require extra information on diet, medications and that, so we can get resources from the Heart Foundation and just mail it to them as they require them.
What we do here at Royal Perth, we have a cardiac rehab service that you can come back to, but because you're from Albany, what we would try and link you into is something more local. So there's a lovely girl out there that I can refer you to running the service, and what I do is I send your information to her when you've been discharged, so she's got all the information about this admission, and she'll then follow you up by phone and link you into the services that they have there. And you can take your wife along. Are you married, is it?
Yes.
Yep. So you take your wife along and you can all get that information. Everyone's on the same level of information about their heart. There are some cardiac rehab programs set up in the major rural centres, and there's a directory for those if you want to find out about those on the ACRA website. But if we can refer them into that, then we'll try and refer patients into that service so that they are getting a type of program to what we would run here. And a lot of those do have the multidisciplinary teams attached to them, but maybe not as many staff as we have. But otherwise, if they don't have a cardiac rehab program that they can tap into in the nearby to them, or if they can't, they might have it there but they can't access it because they're getting back to work or what have you, then we might look at referring them into the coach program, which is our telephone follow-up program.
So what are you doing to help with that? I'm Helen McLean, I'm the cardiac coach at Royal Perth Hospital. My job is to go and meet patients in the ward situation, patients who live in rural and remote areas, patients who work in full-time employment, and patients who are unable to get into the cardiac rehab sessions at Royal Perth, and I provide them with a telephone follow-up. And I go through all the risk factors for heart disease with them. A little bit of chest pain, so what did you do then? Sat down and had a rest, that's great, good. And did you follow, have you got your magnet on your fridge at home? Good. The first thing I do with them is I go through their chest pain management and make sure that they will get help and that they have their magnet from the Heart Foundation on the fridge, and that they know that they have to get help in the next 10 minutes if they've got ongoing pain. I then go through their medications with them and make sure that they are taking all their medicines, any questions, any explanation of their medications, and ensure that they're compliant with their meds. I talk to them about their lifestyle factors, their exercise, nutrition. I talk to them about their weight and their waist measurements and help them with strategies to lose weight, stop smoking, exercise more. And how have you been going with your exercise? 10 to 15 minutes, good, that's really good. Yeah, and the thing about it is to have it regular and make it part of your day. That's the most important thing, because then you can build on the time with it. And even if you can do 2 lots of that 15 minutes, then you've found 30 that the Heart Foundation want you to. Okay? And yeah, and how are you going with this stopping smoking? Basically, you stay in the coach program for 6 months, some people up to 9 months. Some people may only have a couple of risk factors. They might be a smoker and have a bit of high cholesterol. Once their cholesterol is taken by you, the GP, it comes back, it's good, and they've quit smoking. So we may be able to let them graduate from the program before the 6 months. Other people who have lots of weight would never actually achieve all their risk factors. So we keep them going till they're comfortable that they have lost some weight and they're on the right track. Now, the GP will be checking your cholesterol and your HbA1c. Yeah, it should just be in the next month, so I'll make sure I give you a call before the month's out. I'll send a letter to you and a copy to the GP so that he knows to take your cholesterol and your blood sugar check. When they graduate, I always say ring me with any heart problems, any questions you have, but you actually are their primary focus now, and it will be you they'll be coming for the rest of their time to have 6 monthly checks of their blood pressure, their cholesterol. If they're diabetic, they should have 3 monthly checks of their HbA1c, and just ongoing maintenance of their lifestyle changes that they've made.
A cardiac event is a major life changing event for many people, so it's a really good opportunity to implement behaviour change, especially in people who historically haven't been physically active. And some people can be a little bit apprehensive and a little bit nervous about starting an exercise program, but with the support that they get from staff and the other patients who are attending the program, they're able to achieve an improvement in their exercise capacity and improve their confidence for physical activity. And this is really important in encouraging people to maintain a long-term adherence to physical activity, which is ultimately, what we're trying to achieve.
We're happy for you to contact us, and we'll try and give you any information we have about what can help your patient in terms of their cardiac rehab recovery. Use
Cardiac rehab, we're here for your patients, and I'm here for our Aboriginal patients. So the more that I can be used to help you guys, it's all a good thing.
Our thanks to the entire team at the Cardiac Rehab Service for their time and assistance. Let's now rejoin the discussion with Drs Olga Ward, Jenny Deague and Ian Dey.
Jenny, could you talk us through managing patients who have really intractable cardiac pain despite what I guess would be maximal medications that are normally introduced in the community?
Yeah, these patients are a very difficult group of patients. The first thing is to go back and see, is there anything that can be revascularised? So is there any stent or bypass surgery or something that can open up the arteries? And then if they're still on maximum beta blockers, ACE inhibitors, aspirin, Plavix, and they're still getting this intractable pain, you've got nitrates, which are still very good. And then the newer things that can be used are things such as Icaral, which can help, which has a bit of nitrate and a bit of a potassium channel blocker as well.
Icaral is Nicorandil, yeah?
That's Nicorandil, yes.
Is that new?
Oh, well, I guess it's old and new. I guess if you think about what you need for these patients, when you see a patient with intractable cardiac pain, the first thing is to make sure that they're on the basics. Are they on aspirin? Are they on beta blockers? Are they on a statin? Are they on ACE inhibitors? And everything else after that is a bonus, but the basics are the important things to get right. The second thing is there anything we can revascularise? Is there something we've missed? Has the person got a new lesion? Have they re-stenosed a stent? Has their bypass graft stenosed? All of that. Then you can talk about nitrates, Nicorandil, or Ivabradine is probably the newer thing on the market, which works on the sinus node. It works purely on the sinus node, and it's available for intractable anginal patients who have heart rates over 60 beats per minute but still have angina despite being on the maximal medical management.
And what does it do to the sinus node? I don't know this drug at all.
It slows the heart rate, so it's by heart rate slowing it reduces angina. So it works on the channels, the sinus node channels.
Do they still have any kind of exercise tolerance, given that they can't raise their heart rate then?
Well, if they've got so much angina that they need to be on Ivabradine, they're probably not able to exercise very much. So in fact, if you can relieve their pain with exertion, they will have better exercise tolerance. And it can actually be added to beta blockers. So you could see a patient with intractable angina who's on aspirin, Plavix, beta blockers, statins, ACE inhibitors, nitrates, Nicorandil, and ivabradine. Now that would be, in the circumstance you've got that patient, that's a very rare patient. And I think that's where you need to think back to the basics. Is there something I'm missing? Is there something I can revascularize? Is there some other way to get rid of the pain? Or indeed, is this intractable ischemic pain, or is this something else? Should I be looking for something else in this patient?
What other things might you have missed there then, Jenny?
It's possible you've missed simple musculoskeletal chest pain, or they've got a pulmonary embolus this time, or they've got non-cardiac chest pain, gastroesophageal reflux disease. There are lots of other things that it could be. And always when you've got people on that many medications, you need to really be able to justify it quite strongly.
Ian, do you have anything to add to that, those sort of patients that come in?
Yeah, look, they're a difficult group of patients because they do present to the emergency department and you're left wondering, is this their intractable angina? Is this something else? And of course, the other reason they commonly present is directly related to medication side effects. Syncope and breathlessness and other common sort of directly related side effects of those medications. So I think it is challenging, but it is important, as Jenny said, to keep an open mind about what else they're possibly presenting with, and the fact that they may have severe coronary vascular disease that can't all be corrected doesn't stop them coming in with all of the other causes of pain. The relevance of which is that you don't necessarily reflexly look to increasing anti-anginal treatment, that sometimes the introduction of another treatment may both solve their symptoms and maybe even allow you to reduce some of those medications perhaps. It's about keeping an open mind, I think.
And don't miss the anxiety and the depression that can come with long-term cardiac disease and long-term pain, and also the benefits of physical therapy, just getting out there and doing some light exercise. And that's where, you know, cardiac rehabilitation and cardiac gyms and things can be really helpful. But even in the country, just basic exercise like walking the dog around the block or joining, you know, going to the local swimming pool and walking classes and things like that can really be very helpful for these people. So I think you do have to keep an open mind. And I know, you know, my friends the geriatricians say their main job is taking medications off patients. And we've always got to think, is there justification for this medication?
There certainly seem to be a lot of medications introduced for the, you know, the over 90s who have minimal symptoms, and then certainly GPs spend a lot of time scraping them up off the floor with their syncope.
That's exactly right, and we see that too.
Yeah, and I mean, I guess hospital medicine's classic for introducing a new medication each admission and not slashing other medications. And I guess at every opportunity, as patients age and their disease patterns change, we've got to look for what's still relevant, what's not, and with each presentation consider what part of this presentation is directly related to medication side effects.
Yeah. Now, in this current modern medical environment, we can treat most things and we can have a go at treating most things. Are there patients with intractable cardiac ischemic pain that you simply can't treat?
No, I don't think there is. I think there's always an option. I think you've always got to be open to different ideas. I mean, you know, one of my patients has been cured by Reiki. That's fine. Okay, if she feels better on her Reiki, that's absolutely fine by me. So I think there's always options and you've got to be open to it. I actually think making sure they don't have anxiety, depression, and that a low-dose antidepressant can't help them, or getting involved in the community, is something that we often miss. And I don't believe that, you know, there are many people out there who can't be helped and whose pain, while cardiac disease can't necessarily be cured, it can be controlled. And I think it's important to be optimistic and to offer the patient hope rather than just giving up. And nowadays, you know, always look, is there something you can revascularize? You know, we are stenting more and more things more and more successfully. We have much better results. We need to be open to this. The new cardiac surgical techniques, a lot of them percutaneous, are a great offering. You know, the patient may have had anginal chest pain for a long time, but now they've developed aortic stenosis. So let's diagnose the aortic stenosis and let's get them a new aortic valve, whether it be surgically or percutaneously. I think you've always got to be open. You may have known someone for 10 years, but 10 years is a long time in a patient's history.
And a long time in cardiac techniques.
A long time, yes. Re-evaluate cardiac techniques. Are there new options for this particular individual patient?
Yeah, my experience is similar in that at the emergency side, there's very few patients that we would assume that nothing can be done for. It's just that for some of them, it's not as simple as a standard coronary vascular intervention or another anti-anginal medication. What you do for them may be something slightly different, but very few patients that you can offer nothing.
Yeah. So if you've got say a fairly frail elderly patient in a country setting and they're presenting with chest pain which might be acute each time or on a background of kind of easily set off chronic pain, how would you go about working them up?
I think this is where the GP is absolutely vital, because you know your patient, you know your patient's community, you know your patient's family, and so you will know whether this 90-year-old will benefit for a stent or not, whether the risk-benefit is appropriate in that individual patient. Obviously, with the frail and elderly, I would prefer to treat them with medications and hope that everything settles down. And you have to be judicious, because a 90-year-old may well not tolerate beta blockers, which your American guidelines may tell you should be giving him. But with that caveat in place, if this 90-year-old has a very simple proximal LAD stenosis of 90% that can be easily stented and can improve their quality of life, well, that's a fabulous answer.
Yeah. And normally in a country town, this sort of patient would come through the country emergency department. Are they appropriate to send through via a tertiary hospital ED?
Yeah, well, yes, I don't think age should determine exactly what's done in terms of workup within the bounds of common sense, because I think diagnosis is so important in terms of working out what the sensible interventions might be. So I think age shouldn't necessarily determine whether you just treat something empirically or work towards a diagnosis. I think you need to know what's going on, and once you know what's going on, then you can work out risk-benefit sort of profiles of the various interventions and have a sensible discussion with families and a sensible look at where that fits in for the patient. But take that patient, for example, the frail elderly patient in the country with recurrent presentations of chest pain. What's important is working out, is that coronary vascular or not? If it is coronary vascular, then there might be a relatively simple intervention that solves the problem. If it's not coronary vascular, then that's useful to know as well, of course. But we're not ageist.
No.
No.
Both of you have at various stages mentioned protocols that you use, or protocols that are used. Are there any really helpful protocols for, say, the treatment of acute chest pain that GPs could look up on the net or have pinned up in their emergency departments?
Yes. I think that the Heart Association guidelines are probably the best. I think that they give you a
the American Heart
public
Association?
Access. No, the
Cardiac
Society of Australia, and they were published in 2008 was it in the MJA, and are commonly available. And I think there's been a recent update as well. There's a 2011 update, I understand. They're very readable. They're comprehensive. They give you a really good framework for dealing with chest pain, and in particular sort of risk stratifying chest pain, which then starts to determine what interventions are appropriate and the urgency of those interventions. And I think what's really useful for particularly rural practitioners to know is, when you've got an acute coronary syndrome, what do I need to do? But more importantly, what timeframes does it need to be done? And is this something that RFDS need to come and pick up now? Is this something that can wait a few days? Is it something that can potentially wait a couple of weeks? And I think understanding those Heart Association guidelines gives you a really good framework.
Yeah. And the RFDS protocol has that similar
Certainly
protocol.
The RFDS has chest pain protocols, and they also have a thrombolysis protocol, which is very clear and easy to read.
And available
and also
on the web.
And suitable to country emergency departments. When you're trying in a country emergency department to work up a patient like this, who would you suggest we talk to? I mean, would you in the first instance ring an emergency department or an RFDS doctor or a cardiologist?
I think it's who you know. I actually think, if you know someone face to face, whether they be an ED physician or a cardiologist, it's nice to speak to someone who you know and
who knows where you're at.
And
Yeah.
knows where you're at. Because I think that's always great. And I think that's where our health system needs to improve, because we need people, there needs to be a cardiologist who covers a rural area, who's the go-to person who you can call about curly problems. I think that would be really good. So I think the first step would be, is there someone you know who will be available to speak to you and give you advice?
Ian, do you get country doctors on the phone a lot?
Look, I think less than we used to, which either means that they don't like our advice or they're getting it from elsewhere, cardiologists and RFDS. I hope it's the latter. Look, I think that it depends. It probably depends a little bit on, like Jenny says, who you know, and I never underrate the importance of just your local networks, if you like. But I think it depends too on if you've got to the point where you think this is acute coronary syndrome, then a cardiologist is the person to speak to. That's their domain.
Yep.
If you're in the position where this is chest pain and you've got no idea what's going on, or it's a diagnostic issue or a management of an undifferentiated chest pain issue, then I would think any emergency physician would be happy to take a call and offer advice on that.
And do the tertiary hospitals have facility, like I know we can fax ECGs, but do you have like electronic facilities if you wanted to, say, view a chest x-ray that you weren't quite sure about, or a set of results that you weren't quite sure about?
We've still got fax machines, so ECGs can be faxed. X-rays.
I have been known to take a digital photograph of an X-ray and email it.
Yeah. Look, there's email facilities, but not dedicated email facilities on the as a sort of a group email, if you like, on the floor. Teleconference sort of stuff is still in its relative infancy for a lot of the EDs. Digital X-rays, they have to be uploadable at the source end to the public PACS system to be visible. So, look, it's limited, and probably in reality is mostly just viewing a faxed ECG.
Yep. And does either of you have any final points that you'd like to make about managing chest pain?
I think if I was to say some takeaway points, I think those the Cardiac Society guidelines are really useful. I think if you've got to the point where you're thinking acute coronary syndrome, then a lot of the money's in risk stratification initially, which includes things like your ECG and your troponins. A do not miss kind of mentality. So when you see a chest pain, just that quick thought, if it seems simple, just that mental check that you're not missing acute coronary syndrome, you're not missing PE, you're not missing dissection. They're, I think, my takeaway points. And beware the patients with ongoing chest pain where you don't have an alternative diagnosis. Most of the events I've had been asked to review where patients have subsequently had an arrest, for example, have had ongoing pain and or just subtle ECG state changes. So beware those patients that don't have quite enough ECG changes to get everybody enthusiastic, but have ongoing pain.
Well, thanks very much, both of you, for joining us today.
Thank you.
Well, that's all we have time for in tonight's programme. Once again, our thanks to Dr. Jenny Deague, Dr. Ian Dey, and of course our own Dr. Olga Ward. And remember, this programme or any of our programmes going back to 2008 are available to access on our website, ruralhealthwest.com.au. And full sets of the 2009 and 2010 DVDs are also currently available for just $80 for a set of 10 programmes. To order, simply call Rural Health West reception on 08 6389 4500. We're back on the 2nd of August with a programme that looks at respiratory problems. Until then, Jerry Gannon on behalf of the team saying thanks for joining us.